There we go. Thank you very much. And the first thing we're actually going to do before I hand you over to Chris to carry on is we would like to gather your thoughts and feelings about how you're feeling about the ICS at the moment, the integrated care system. So what we're going to do is we're going to do a quick poll. And this should be about to appear on your screen shortly. This is a Menti poll. So what we would ask you to do, if you're happy to take part, is to open up your internet. So go to a web browser. You can do this either on your laptop or on a mobile phone if you've got one by the side of you. And you need to go to www.menti.com. For those of you that can see it, it's actually on the top of your screen there. And once you've got onto that, there's a code to type in. Okay. You will see in the chat box, we've put in the web address and the code. Please don't worry if it says something like it's blocking it or you're not allowed on. We've practiced this several times and it is okay, we promise. So please persevere if you can. And the first thing, after you've put the code in, which is 70279310, it will ask you for 3 words. And we'd like you to share your thoughts with us. How are you feeling right now when we mentioned the ICS, the integrated care system? Excellent. Someone's made it onto there. I can see some comments appearing as we speak. Thank you so much for that. We're going to give it a couple of minutes because obviously you have to get onto the website, put the code in, and then think of your words. So we're just going to pause slightly and give you a chance to do that. Wow, here we go. We have some thoughts being arranged before us. Thank you very much, everyone. While people are doing that, I'm still admitting the last few people, but while people are giving us their comments, I will just say thank you very much. Enjoy this session. And once we're ready, I'll hand over to Chris and he'll continue.
Oh, there's some interesting comments there, isn't there?
Good.
Right.
If we just give it another minute, and then hopefully we'll get everyone admitted in, and also everyone will have a chance to have done it. Okay, I'm handing over to you, Chris. Thank you very much. Have a great session, everyone.
Yeah, that's been a really helpful insight into the way people are feeling. Clearly, there's still degrees of confusion about there, but people are wanting to engage, feeling quite optimistic, curious about it, excited, but needing further information, further clarification, which I hope we will get from Danielle today. And the reason that we're running this event is actually captured in this little word cloud, is because it is our view that the voluntary sector has an opportunity to be fully engaged with the integrated care system. But it will only do that if everybody is fully aware and understanding what the ICS is and how it's going to work. And in my experience, the only way that happens is when the person who is making decisions in the ICS, which is Danielle, can talk directly to people who are trying to get involved in the ICS, so they can have a direct dialogue with each other. It's really important, I think, in my view, that the voluntary sector has a much greater understanding and involvement in the ICS. because the changes that will be brought in by the ICS are long-term and fairly profound. It would be helpful as we go through, colleagues, if in the chat you could put your name and which organization you're from. I meant to ask that at the beginning, but as we go through, if you've got a moment, if you could just pop your name and your organization into the chat, it just helps us with the with recording this event and saying who was here. So what we're going to be doing now is we'll be showing a 5-minute King's Fund video about, I think it's actually 6 minutes, isn't it, Deb? 6-minute King's Fund video, which explains and describes the integrated care system. Now, some of you will have seen this before, and some of you will have a more developed understanding of the ICS. So my apologies for having to sit through this. But I think it's important that everybody on the call gets an opportunity to see this video, because for me, it's a really good explanation of what the ICS is and how it's intended to work. So if you'll bear with us, I'm going to cross my fingers that the technology works, Deb.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health, and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents, and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
Right, I think that's a very helpful video. I think from the King's Fund, it puts what are often quite complex concepts into plain English, which I think helps a lot of people. Has it sparked any thoughts in anyone about what you'd like to discuss when Danielle arrives, which you haven't already submitted? You can either put those in the chat, or you can put your hand up now and we'll see if we can get to you. Charles Goody, I see your hand up.
Yes, I couldn't resist, Chris, as you well know. Chris, there's one thing that's key in the whole thing. Nowhere is the word patient really mentioned, because what we need is integrated patient care, not integrated service suppliers. We've had this debate going on for the last 15 years, and we've changed organizations and changed them, and it's made no improvement because we're not focused on the patient. So when are they going to start organizing the services around patient care? So we have someone responsible for the holistic care of a patient. That doesn't appear anywhere in this debate.
That's a really good point, Charles, and it might be one that when Danielle does arrive, can I bring you in and ask you to say it again?
Okay, if I can remember.
Well, if you don't, I'm sure other people will.
Thanks.
Now, the sorts of questions that were coming in before this event were covered three broad areas. One was about an improved understanding of the integrated care system and what that would mean for working practices and what it would mean for true integration, and whether it can put an end to things like the postcode lottery. So there was a whole series of things about a greater understanding of the ICS. A second broad area of questioning was about the implementation plans for the integrated care system and looking at things like the timetables and what the changes will actually look like on the ground. So there are a whole series of things, and people pulled out specific groups that would be affected by it. And the ones that I'm reading here are people with a learning disability, people receiving home care, carers and the impact on them, and working with people who have complex needs and multiple health challenges and how the ICS will respond to those challenges. And the third area that people wanted to explore in more detail was to understand more about the role of the voluntary sector in the ICS and in the engagement that the ICS says it will be carrying out. So those are the sorts of three broad areas that people were talking about. Are there any others that you would like to bring up when Danielle does arrive in a few minutes' time? Are there any other points that people want to make at this point? Andy Lawrence says, I'm happy to hear healthcare is on, home care is on the list. What else have we got here? Sue Jenkins wanting to talk about cancer services, which I think is important. Jenny Bannon agreeing that the focus should be on people and population, not on organisations. Agree with that. Are there any other issues that people would like to raise before Danielle arrives in about?
Hi there. I can't seem to find the way to put my hand up on Zoom, so I'm just shouting out. Hi, I'm Leslie Terry. I work in HWW. I just would really like to hear from Danielle about how does the development of ICSs and places and care collaboratives and all the rest of it, how does that get us closer to bringing together NHS and social care with the wider determinants of health? So, you know, we are talking now about population health management. We're talking about that greater link between understanding the, you know, the 80% of wider determinants that actually impact on your health. And that is, you know, something we're starting to understand in the NHS and something we're starting to get really excited about. So how does the development of ICSs and the various structures and governance and collaboration that comes with that, which is really still just within the NHS and social care, how does that link into us being able to influence or impact on the wider determinants? Or is that sort of outside of the scope of this? That's a very big question, sorry. But yeah. I'm really keen to hear Danielle's views on that. Thank you.
Yeah, and yes, it will be interesting, both in terms of how local government and the NHS work together. That is an important point, but it's also how it works with the voluntary sector, so that the whole system is working together. And in terms of tackling some of the wider determinants you've already identified, and there are, as you know, many others, then the voluntary sector for me has a key role to play in ensuring those things are properly on the agenda. And that's part of the reason that we called this meeting today, was to ensure that Danielle heard some of that. So thank you for that. It's a really helpful input. And somebody's put in the chat, how will social care and health funding be explained to patients receiving home services? And I think that's a fair point. And what else have we got here? Preventative work in the community. So we are doing less crisis intervention in various fields such as mental health, homelessness, substance abuse, and so on. I think that's important too. I think the point about public health, in the King's Fund video, public health was specifically referred to as one of the objectives of the ICS. So it'll be interesting to see what that would mean in practice. You know, it's easy enough to say that. How will the ICS help to raise awareness of local activities that national charities can deliver to support people? So people keep coming through on this WhatsApp and I can't read it. Okay, is there anything else? Is anyone else got anything they want to add at this point? I will pick up some of those and put the questions to Danielle when she arrives. Right, and Robin has said, I would like to know more about the readiness of the 4 places and the various collaboratives to work to contract. I think we'd all like to know a little bit more about that. And Addy has put in, keen to know how the ICS can and will reach groups such as homeless and rough sleepers. And I mean, Healthwatch Warwickshire has done some work with people who are homeless and their ability to access services. Yep.
Hi, Chris. I know you've got your head all over the place at the minute. So
Yep.
just to let you know that Danielle has indeed joined us. So welcome, Danielle. And back to you, Chris.
Danielle, welcome.
Hi. Thanks for inviting me.
Well, I'm really grateful to you for giving up the time to be with us today. There are a number of issues that have been raised in the chat already, coming out largely the King's Fund video and related things. But would you like to just are you all right now? Just to kick straight off, just to start, are you?
Yes, I am. Yes.
Well, would you like to introduce yourself? I mean, I will do a little bit about it. Danielle is chair designate, because it hasn't started yet, has it, of the Integrated Care Board and the Integrated Care Partnership. And Danielle is also on the National Committee of Healthwatch England, because I've seen you in action there, Danielle. And also has a long history of involvement both with Healthwatch and with the NHS. So Danielle, would you like to just say a few words to people?
Yeah, thank you. Really pleased to be here. I suppose a couple more points about me. I have been involved in chairing a couple of NHS trusts over the years. And I've also been involved in housing boards and chaired a housing association quite recently. In terms of my executive career, I started off in the private sector for about, I don't know, maybe half of my career in fine arts, book publishing, which is completely different, and then moved into community regeneration in the public sector and the voluntary sector for the last half of my career. And then now I'm focusing on non-executive roles. So that's my background. I suppose the last two voluntary sector roles that I had were national roles, and that was with the Groundwork Federation of Trusts, and also with the Conservation Volunteers, where I was Operations Director for Employment and Skills. So, you know, I have got an affinity with the voluntary and community sector. I did a master's in equal opportunities, and we had to write a dissertation. And my dissertation was on the role of the voluntary and community sector and how it can be engaged and exploited by the public sector. So I'm very keen to have a meaningful conversation with you about how we can work together to bring to life some of the common pitfalls and to sort of work around those and through those so that we can really add value to each other's work. So I've been asked, I don't know, Chris, how long have I got to speak? I don't think I know that. I better just make sure that I don't go over time.
It's a sort of how long is a piece of string, really.
Oh, okay. Well, I want to leave time for us to have
time for a bit of clarification.
So I was planning to start off with a bit of an overview of the integrated care system and just checking to see that people aren't saying, oh no, we know it all and we don't want to hear that.
No, we did do a word cloud a little bit earlier on, and we asked people how they were feeling about the ICS. And some of the dominant themes that came through were, some were hopeful, some were confused, a large number of people were interested, some were apprehensive, but by and large there was some positivity towards it, but needed a greater understanding.
Yeah, okay, good. So that's worth doing. And then I'd like to talk a little bit about where I see some of the challenges and some of the things that I think that we should be doing together to overcome those challenges, and then have an open two-way conversation so that we can not just Q&A, you can share reflections and things like that, so that we can talk about how we're going to move things forward. So in terms of what the integrated care system is, I suppose it is what is different about it from what we've got already. So we've become a statutory integrated care system for Coventry and Warwickshire from the 1st of July. The aim is that we're going to be able to break down the barriers between organisations and join up health and care more effectively so that we can actually make a difference to people's lives. This is the sort of thing that has been talked about for many, many years, but we're now in a position where national policy is actually stating that that is what we should be doing. So that's really positive. The other thing that I think is really positive is there's a very explicit emphasis on addressing the wider determinants of health, such as poor housing and socioeconomic problems. And it should enable us to bring the right resources from across organisations to tackle public health issues, for example, obesity. So I think in addition to improving the quality of health and care services, by working in partnership across the integrated care system, it should enable us to address the levelling up agenda, which is specifically about spreading opportunities involving public services, especially those where public services may be the weakest, to be actively involved in restoring a sense of community, local pride and belonging, empowering local leaders and communities, especially in places where they're lacking local agency. And this is really now starting to play quite explicitly into the agendas of local authorities, and in particular, I think the agendas that you're working towards. But I think we're open to that conversation a little bit later on in our session. What's really clear is this is not an agenda that the NHS can deliver alone, and even the statutory sector more broadly cannot deliver this alone. It's about shifting from competition to collaboration, and that requires a step change, particularly from people who have developed their careers in that competitive environment. And it necessarily requires meaningful engagement with the communities that we're meant to be serving, and therefore we will need meaningful involvement with the voluntary and community sector. So the 4 aims of the integrated care system are the same for every integrated care system up and down the country. They will be interpreted in different ways to meet the needs of the population, but essentially they are to improve the outcome in population health and healthcare, to tackle inequalities in outcomes, experience and access, to enhance productivity and value for money, and to help the NHS play its part by supporting broader social and economic development. And I think that's really important. So the integrated care system will help us to improve quality by aligning standards and expectations and sharing intelligence. But the criteria for success will need to be developed with partners against those aims. So not taking over the work of the Health and Wellbeing Board, but working very closely to make sure that we've got really locally focused aims that have been stated in those health and wellbeing strategies that are grown from the joint strategic needs assessment, so very much local population based, but then align with those 4 priorities within the integrated care system strategy. And for me, it's really clear that voluntary and community sector is absolutely key within that. So we need to be able to get upstream We need to be able to work with partners to create the conditions to prevent ill health, to support healthy life expectancy and improve the life in the years as well as the increase in the years in life. So that will necessarily involve listening to the voice of the public, listening to the voice of patients and carers, and shifting the focus from what's the matter with me to what matters to me. All of these may sound really obvious to you, but that is not how the statutory sector, the NHS in particular, has been accustomed to operating. So this is really new territory. So we need to empower citizens to be involved in influencing service design and to take ownership of their own health as well. So there's a two-pronged approach that I think is really important. And the tendency, I think, in the NHS in the past is to put a lot of emphasis on the individual taking responsibility for their own health and less emphasis on the citizens being involved in what the service design should be to respond to that. So by working together, we can improve quality, promote the latest improvements in delivery models, maximize technology, all of those things, but also reduce demand on the most expensive resources by working upstream in communities to prevent ill health in the first place. Additionally, we are anchor institutions. The large organisations, particularly public sector organisations, have got a duty to make a contribution, for example, as employers, making sure that they're contributing to the local health economy by offering access to jobs, good quality jobs with prospects. The way that the system is organised is that the Integrated Care Partnership, which has got two voluntary sector representatives and Health Watch, two places for voluntary sector representatives, the local authority, academic institutions, as well as health, and sets the strategic context. So it will develop an integrated care system strategy, drawing upon those health and wellbeing strategies, as I mentioned. Then the Integrated Care Board, which is the NHS body, must take due regard to that strategy when it's making its plan for how it distributes its resources. Now, I'm the chair of both, so it would be absolutely nonsensical for me to be out there engaging with communities and voluntary community sector and partners, coming up with a strategy that really is shifting our emphasis and turning everything on its head so that it's meaningful for citizens, and then go back and allocate the resources in a completely different way to the Integrated Care Board. So this is the challenge, really. Set the strategic context and then make that change happen. And it is going to be a hell of a journey. Let's not underestimate what the challenge is going to be. It feels complicated, and I think that's partly NHS does have a tendency to make things complicated, and perhaps, you know, we could have devised a system that wasn't quite as complex. But as you know, this is a national approach, and I think we take the benefit of the fact that nationally they are encouraging us to take a health prevention focus on inequalities and social economic inclusion, and we accept the fact that along with that we have structures that maybe not exactly as we would have designed them. We just need to run with it and make it work for us. So we have alongside the Integrated Care Partnership setting the strategy, the Integrated Care Board allocating the NHS part of the resources. We have the two health and wellbeing boards, and the health and overview and scrutiny committees remain in place, very important for that democratic accountability. In terms of delivery, we will be looking to develop collaboratives that encourage organisations to work together and to respond more directly to the needs of the more local populations. These are all in development. So that's the sort of landscape. The other thing I should say is that we've got non-executive directors that have been recruited to the Integrated Care Board, and they come from a wide variety of backgrounds, including voluntary and community sector. So why does the integrated care system need to work with the voluntary and community sector? I think a really obvious example is in the pandemic, which even in Coventry and Warwickshire particularly, there's been some really fantastic examples of partnership. The vaccination programme, for example, really drew heavily on relationships with community sector, faith networks. We've got the example of Grapevine's work on healthy communities together. There are loads of examples of good pieces of work, which now I think they're like proof of concept. If anyone needed to understand why it's worth working with the voluntary and community sector, the pandemic has made that really clear, because actually you can't reach the communities that you need to without it. So we've all faced a lot of challenges. We've all needed to shift our focus, and we've all needed to move our priorities so that we can support local communities. We've had to adapt to new ways of working. We've had to work virtually. We've had to transfer resources to achieve impact and adopt a fast pace of change. And the voluntary and community sector has been part of that, and they've shown the innovation and the creativity that statutory sector have been playing catch up. So I think for individuals and organisations not accustomed to working with the voluntary and community sector in a meaningful way in the past, not clear on the value, it is now writ large. It is as stark as the inequalities that are existing in the communities as a result of the pandemic. And in addition to that, NHSE nationally have been very explicit about the importance of involving people, communities, and the voluntary and community sector. And as you know, the NHS traditionally has been a very hierarchical organisation, so it's really helpful to have a national policy recognising the importance of the voluntary and community sector. I think to make it happen, there does need to be a cultural shift. There needs to be a move away from a sort of patting on the head type of relationship, even a move away from just seeing the voluntary and community sector as providers. It actually needs to be a relationship of partners, of equals. It needs to be a relationship where the knowledge and the expertise in the voluntary and community sector is valued, because actually we will not be able to reach communities, we will not be able to understand their needs, we will not be able to shape the delivery of services in ways that genuinely engage, and we will not have the flexibility of fleetness of approach if we don't work as equals. If everything is designed by the NHS and handed out to the voluntary community sector to interpret, and by the way, that understanding that voluntary doesn't mean free, all of these things is a step change, and it is going to involve hard conversations, and it isn't something that's going to happen overnight. But it needs to be that the voluntary and community sector are playing lead roles within the system and not just there at the periphery. So I think the voluntary and community sector as key partners will be providing insights and access to communities who may be hidden, that sort of street level consciousness. And I just pause to give you a little anecdote. I went to a community event at an Islamic Resource Centre in Falls Hill, and it was a wonderful event. I saw all sorts of teams from across health and social care talking really passionately about the work they were doing to be responsive to local communities. I was really, really impressed I talked to social prescribers, family hubs, women's health, etc. And I was really pleased with what I was hearing. And these were people who were clearly wanting to be rooted in the community and reach out to the community. Then after the speeches, when I introduced myself a little bit, people then realised who I was and wanted to talk to me about their particular circumstances. And there were two that really stuck out for me. One was a man who was talking quite embarrassedly, but he had picked up the confidence to talk to me about the mental health needs of his two daughters, and the need for them to have some structure in their lives. I was really excited. All the social prescribers, they were wonderful. They can help. You know, maybe there's some volunteering opportunities that the daughters might like to be involved in. Or, he said they just need a reason to get out of bed. So I went over and introduced him to the social prescribers. And of course, this man who had plucked up the courage to talk to me about a set of circumstances that he found to be deeply embarrassing, then had to tell his story again. And the social prescriber's response was, you know, I need to understand what GP practice you're in, and you know, basically the eligibility criteria. So it just sort of sucks all the energy out of that conversation, and it was really hard to come back from that. And the other one was a lady who held my hand and talked to me about a neighbour that was experiencing domestic violence, but nobody in the community can know about it. What do we do next? Who do we talk to? And of course, in both of those circumstances, the role of the voluntary community sector is absolutely key. Just by going straight to the statutory sector straight away, you're just talking cross purposes, perfectly well-meaning, but not having the language where they could actually understand each other. So I think that for me, those were two examples that really brought it home to me, the importance of working with the voluntary community sector. So supporting with accessibility needs, leading focus groups with communities that are known to particular organisations, helping the ICS to make sure that change is actually people-led and not policy-led or organisational structure-led. And as I said, actively involved in shaping the strategy for the whole system, and specifically with two roles on the Integrated Care Partnership that will be drafting the strategy. I think some of the changes that we need to work towards is that it does need to be a relationship of equals. It needs to be more transparent than it's been in the past. It needs to be more authentic. I would say that is going to be a journey, because people don't understand that that's not how they're being. You have to explain that to people. People come from a certain point of view, from a certain set of experiences, and they don't necessarily realise that they're not being inclusive, or they're not being respectful, or they're not valuing a contribution, because that's not been their own experience. So we're going to have to constantly reinforce that. Start off by setting the principles of how we work, and then by holding people to account, and also bringing them along, holding their hand along on that journey. The sorts of things that I would like to see are regular meetings between leaders of the voluntary sector and ICS leaders. And when I say ICS, I mean including all parts of the ICS, so local authority, primary care, the trusts, etc. So, you know, us working together as leaders, working together collaboratively on funding bids, co-designing services, looking at shared use of estates. Maybe there are aspects of public sector estate that are underutilised that could be used by voluntary community organisations. Maybe there are opportunities for joined workforce approaches in some areas. And of course, we've got to get a community and people strategy that everybody's involved in shaping. So I think why would the voluntary and community sector be interested in being involved? That's, I think, where we need to have the conversation. From my perspective, I say that the 4 priorities that the integrated care system are working towards, which is way beyond what the NHS has traditionally been. The fact that we are looking at the wider determinants of health, looking at addressing inequalities, looking at involving communities in empowering them in taking ownership of their own health. For me, I'm hoping that you feel that that is bringing us much closer to the agenda that you've been working on for the last however many years, but for many, many years. And so I'm really hoping that you'll want to get involved in this journey together. So that's my introduction. I'm really open now to questions or comments.
Yeah, that was very rich. I really enjoyed that, and I do think that concept that you had of an authentic relationship between the voluntary sector and the NHS is such an important concept. Does anyone have any immediate comments, thoughts, reflections, or questions for Danielle? Sorry, I'm hastily scrolling.
Might be worth me just saying that in terms of what's happened so far, I know that some of you know Rose Owens.
Yes.
And she's been working on drafting a people and communities strategy. And I think she's been working with a number of leaders across the voluntary and community sector. That strategy is only at draft, and more work needs to be done to engage with people to make sure that that is a properly owned strategy. And so the next steps are that some funding has been secured from NHS England to have more in-depth focus groups with you all and other voluntary community sector organisations to really get a sense of ownership on that strategy.
We have a very diverse range of people in the audience, Danielle, and I think a really important point was raised earlier by Charles Goody. Charles, do you want to say what your point was?
Yes, sure. Thank you, Chris. Thank you, Danielle. One thing that doesn't come clear in any of these your talk was that patients weren't really mentioned. I can appreciate that the providers get some benefit from this and they're putting the organizations together and makes them more efficient and so on. But at the end of the day, the health services there is to deliver care to patients. Who is responsible for delivering holistic care to the patients to make sure that they benefit from this and not just the organizations? At the moment, I can't see that the patients will see any benefit from this, but the organizations will.
Yeah, I mean, that's absolutely vital, Charles. It's a really good question. So the reason why I try to avoid talking about patients is because the integrated care system is about the whole population. It's about preventing ill health so that people don't become patients. It's about working with carers. It's about working with whole families and not just patients. Of course, patients are really important, and the first priority for all integrated care systems is the improvement of quality of services for patients. But it is also about getting upstream and tackling ill health, you know, and also encouraging people and supporting people to become actively involved socially and economically, so that they have more purpose in their lives and are less likely to, for example, succumb to mental health challenges, etc. So yes, it still remains an absolute duty for all providers to provide high quality care. They will still be regulated by the Care Quality Commission on that basis. But we will also have a responsibility to fill in the gaps that are not currently being met. So where people are treated as their illness, as opposed to being a holistic person, where people are maybe discharged from hospital and have got several different agencies that they're interacting with and having to tell their story over and over again, and people not sharing information effectively. So the integrated care system is about bringing all of those things together and providing us conditions for ill health and good quality service for people that actually need it.
That means that someone has to be responsible for the holistic care of a patient. Who is that?
Well, we're all responsible. It's a system.
No, but when a patient has got multiple illnesses, who takes on overall responsibility for their care and pulls in the specialist skills as and when required to suit the patient need? At the moment, it's fragmented. Quite often, the patient has to manage the providers, and that gets confusing.
Yeah, so
you've got a number of different telephone numbers to ring and so on. That gets crazy.
Yeah, so that's exactly what we're looking to change. That's what we're working towards. We haven't decided on a particular model for all services. We're at the start of that journey. So the integrated care system goes live on the 1st of July. And you're absolutely right. That's what we'll be looking to address. But at the moment, we haven't got the answers to all of those programs. The idea is that we work together to develop what the answers should be. So you've really well articulated the problem. But if I was to sit here and say, this is the solution, then I've undermined everything that I've said previously, which is about us working together to redesign it.
The point is, we've had this reorganization going on now for the past 15, 20 years. And my experience in the NHS is that this carries on again, and we're just moving the chairs around.
Well,
improving patient care.
Yeah, that could well be the case. My argument is we've got a position here where national policy is saying something that I think we should have always been doing. Let's seize the opportunity and push it as far as we can. Because yes, there's been lots of talk and lots of reorganisations in the past, but this is the first one for me where I've seen them coming out very explicitly in the way that they've done. I think there's an opportunity. I'd rather push really hard and go further than they wanted us to than sit here and worry about it being a cynical exercise. I can't get inside people's heads and understand their motivations, but I could see the opportunity here, and I think we should seize it.
Okay, thank you.
I need to bring other people in, Charles, but it's a good point.
Yeah, sure.
Christine.
She's on mute.
Muted. First of all, can I say, Danielle, that I have knocked around health and social services since the 60s, and up until about the 80s, health and social care worked very closely together. So we're now just revolving the wheel back to where we started. But what I want to ask you is, how do you propose to engage with patients and users? There was nothing about engagement with the users or the patients.
People, engaging with people and communities.
But how?
So that's what the next piece of work is. That's what the people and communities strategy is. That's what we'll be working with you on and colleagues to develop. So obviously there's a whole set of structures in place already. So each trust has a responsibility to work with patients you may think mental health trusts have got more experience in that regard. So all of those systems and processes that exist already, we need to take the best of those and we need to maximize those, but we need to also add this new approach where that's really listened to right at the start rather than at the end when things have gone wrong. So I can talk to you about the principles of it, which is, as a chair, it's absolutely important that people who are using services, people who are caring for people who use services, that their voice is heard and that they can contribute to influencing what services are commissioned in the first place, how services are designed, and then improvements that need to be made in how they're delivered. Those are the principles, and that's exactly what I require in that strategy. However, what the actual vehicle should be is what we need to be designing now.
Okay.
Thank you, Danielle. And one of the key questions that was asked in the run-up to this event was, what will the changes in working practice actually look like on the ground? And I think we're beginning to explore some of that territory, so it clearly is important for people. Nicola.
Thank you. Yeah, and mine relates to what it can look like on the ground. So I'm from Rethink Mental Illness. I'm part of the national team supporting Coventry and Warwickshire in the transformation of mental health. So I do have a strategic role, but I do have a very operational role. And as part of the transformation, and I will say I have 4 experts by experience, so people with lived experience working with me on this. So this is been designed really with people who use services. So using exactly the principles you spoke about, Danielle, really about working together, we've developed in PCNs, kind of multi-agency MDTs, where we literally have health, social care, the police, vulnerable persons officer, the local authority, VCSE organisations who meet the wider determinants of health, housing, and a regular monthly multi-agency MDT, multidisciplinary meeting, where the more complex cases are looked at and discussed as a group. No patient identifiable information is shared, so it can be a very open discussion. And then following the meeting, the social prescribers who are working with the clients then can work with the patient and talk about this menu. But rather than, as Charles alluded to earlier, you know, patients having almost like 15 telephone numbers of organisations, all of these people can work together, offering that more holistic, coordinated package of support. And that's something we've developed in the PCNs in the last year. And I'm working with secondary mental health at the moment, looking at the kind of neighbourhood teams. So, I mean, that operationally is something that is starting to happen in Coventry and Warwickshire. It's working really, really well. You mentioned about the VCSE getting involved, and other than the 2 places on the ICB, what other potential is there to get involved? Because I would be really interested in being involved in this.
Yeah, so there's, as you say, the Integrated Care Partnership, 2 places to be directly involved in shaping the strategy. Then there'll be, I talked about the collaboratives that are being developed, and there's a mental health, and learning disabilities and autism collaborative in development, and also 2 place-based, so 1 for Coventry and 1 for Warwickshire. And I think Warwickshire is even further subdivided into Warwickshire North, South Warwickshire and Rugby. So depending on your geographical remit, you know, those are areas again where I think it's really important to be involved in terms of the strategic round the table focus. Yeah. But then of course there's also the delivery side of things as well, and the engagement and involvement of the communities as deliverers.
Fabulous. Yeah. Okay. I mean, I work across the whole of Coventry and Warwickshire, so.
Yeah. Well, there's absolutely loads of opportunity, but I think, you know, as I said right at the start, we've got to make sure that the relationships are meaningful and authentic. You know, when you've got, you know, statutory sector organisations around the table, people who are well paid and have, you know, they are paid to attend those meetings, and then you've got voluntary sector, community sector organisations sort of struggling to feel people, we've got to make sure that it's, done in a way that is meaningful. So I think that's really clear. I'm not at this point specifying, what should be done, how it should be done, but I think the principles are vital, and that's what we need to be holding ourselves to.
Thank you, Danielle. Leslie.
Hi, my name's Leslie Terry. I work in HWW. I wanted to offer maybe a little example in response to Charles's question, and a question that probably a lot of people will be having around. Well, so what? What does this new ICS thing mean for patients? How does it change what we can do? And I thought it might be helpful to talk about a piece of work that we've been doing in Coventry around patients living with COPD. So it's a chronic respiratory condition. And we got together with patients, clinicians, or I should say people living with COPD, because they're not always patients, they're people just living with this condition, with clinicians, with a social enterprise who supports this group of patients, with people from the voluntary sector and the NHS and the usual sort of suspects we work with when we're doing NHS pieces of work. But we tried to do it in a different way, which was, let's talk to patients first and find out what's important to them, what outcomes are important to them, because we think we know, but maybe we don't know, and maybe some things are more important than others. So with support from some colleagues who are on the call, so Simon Betteridge and people who help with peer support for people living with COPD, we framed it based on what was important to patients. Okay, bear with me, I'm getting to how this is relevant to the ICS. And that's a different way of doing things to how we typically do things in the NHS, which is about service planning and how does the service work, and how does it work for us sometimes more than how does it work for the patient. So that helped us to sort of feel reassured that we were planning something that was helpful or important to the people who we serve. Okay, that's a good start, right? And then we started to think about what are the other things that are impacting on COPD for people, which sit outside of the NHS. So maybe we can talk to colleagues in the council, maybe we can think about housing, maybe we can think about the wider determinants. And we started to build a case for change to improve health and well-being and outcomes for people with COPD, maybe even to try and reduce the levels of COPD, or to impact on prevention and improve people's health and well-being so they don't develop these conditions in the first place. And you can see that working in this way is really exciting for people who work in the NHS, because it's sort of trying to break free from we fix people when they're sick and they come into hospital to we can work alongside people and we can actually start to address some of the wider determinants that really impact on people's health and well-being. But then we get a bit stuck, because at the moment we are NHS organisations, we are council organisations, we are public health, we are voluntary sector, we are social enterprises. We're each doing our own thing. We each have our own budgets, our own reporting to different higher authorities. And it's very difficult because all those organisational structures and barriers are there that stop us from working together. And I think, the hope and the aim of the ICS is to try and bring organisations together so that we have the capability and even the governance and the legal framework to work together, to share our budgets, to share our data, so that we really can start to think about things in terms of how it is for the patient who just sees the things that I need in my life, not I'm on my COPD pathway and the NHS does that. Then I'm on my housing pathway and the council does that. And then I'm on, so I think, Charles, what I'm trying to say is, I think the ICS sort of restructure might help us to be able to start to work in that way, which is actually much more relevant to people's lives. And I don't know if that example sort of brings it to life a little bit. And I don't know what Danielle thinks of that example or if that makes sense. But I just wanted to maybe bring it to life a little bit.
May I comment?
Fairly quick if you can, please, Charles.
Yes, okay. It's just that every patient is different. Yes, COPD is one case, but quite often a COPD patient has other illnesses as well. So who coordinates the care for that patient? Because every patient has a different set of needs, and you need to manage that basis. Organisations can circle around that, but unless you've got someone who is responsible for the holistic care of the patient, you're never going to deliver integrated care to the patient.
Yeah, thanks, Charles. I think that point is well made. Danielle, if I can pick up something from the chat, and then I'll come to Alice, who's got her hand up. You've mentioned some opportunities for people to get involved, for example, in the Mental Health, LD and Autism Care Collaborative. How can people find out about those opportunities?
So from September onwards, there's going to be a series of focus groups, and I believe it'll be Rose Owen who'll be getting in contact to get people involved in that.
Thank you. Alice.
So the new ICS is going to take very much a health preventing health issues and health inequalities approach, but what is that going to mean for people on kind of existing healthcare pathways? There are so many people, particularly I work with people with LD and neurodiversities who are falling between the gaps in healthcare service provision. You know, what plans, what safeguards are going to be put in place to ensure that those people are protected and that actually picked up by services rather when the focus shifts from, you know, shifts to looking at prevention?
Focus isn't shifting away from providing care to promoting prevention. It's just that prevention is now going to be increasingly important. So yes, the learning disability and autism provision is an area where there are some challenges, including access, and that is going to continue to be a focus. You'll recall that I said there were 4 ICS priorities, and the first priority is about the quality of care and improving the outcomes for patients and service users. So that doesn't diminish, that responsibility is still there. So yes, I'm emphasising in my talk, I'm emphasising the health prevention, the inequalities and the socioeconomic inclusion, because those aspects of the 4 priorities are new, and they're also much more explicitly aligned to the work of the voluntary and community sector. But the work that has always been a responsibility for health and social care providers remains, with the hope and the intention that by working together and by taking you know, a more collaborative approach and not competing with each other, that we can improve things further for people who are already using services or for people who haven't been able to access services that they need.
That's all right, Alice. Is that all right, Alice?
Yes, thank you.
No other hands are up. A number of people prior to the meeting, Danielle, asked about how the ICS will impact on the issues being faced by various groups, such as people living with a learning disability, people in receipt of good quality home care. How it will impact on carers is one that's come up a number of times, and how you work with patients and clients with complex needs and multiple health challenges. I think Charles alluded to that earlier.
I think we have talked about most of those points. You haven't explicitly talked about carers, but you know, when I talk about the importance of involving all of the stakeholders who are involved or potentially impacted upon, then the role of carers is absolutely vital. And somewhere in the question in the chats, there's reference to the triangle of care, which of course is absolutely vital. So yeah, that's a really important principle. What I have to be very careful is, as chair, I'm not the executive. I cannot actually tell you specifically, I will do this initiative. I set the context and the expectation and then hold to account. But I'm absolutely clear that when designing whatever the initiatives that we will do, when planning how we will allocate our resources, and when setting that overall strategic context for how we will decide that what we're working towards and how we will measure our success, that has to be done in conjunction with the communities that we're here to serve. Some of them we're currently serving, some of them we're not serving as well as we should do, and some of them we're missing altogether. And a key route for enabling that proper involvement is by working with the voluntary and community sector, because you are much closer to those populations than the statutory sector has ever been.
Sorry, I managed to mute myself again, first time today. There's a question here about seldom heard groups, such as people who are homeless and rough sleepers. Is that something that's going to be addressed through the ICS, as far as you know? I understand you can't make detailed decisions on it.
Yeah, so clearly we have a responsibility to the whole population, and certain groups, certain geographies, certain socioeconomic classes are poorly served and underserved. And that is a key part of what the integrated care system must focus on. Within that, NHS England has developed a framework called the Core 20+5 framework to enable the early thinking and shaping of priorities. That doesn't mean that groups that are not within the priorities shouldn't be focused on, but in terms of making this shift from the blanket approach that's been taken now to something that is more targeted and focused and looking to redress imbalance. So the Core 20 is the 20% most deprived areas of the country. Then the plus are the particular groups that you know, from population health information shown to be in really particular disadvantage. And then 5 services are services which nationally have been shown to have the most impact on disadvantaged groups. So, and I can't remember now exactly which area it is, Coventry or Warwickshire, but essentially, because an important part of the integrated care system is about making decisions nearer to the population served, the integrated care system at system level isn't specifying exactly who those priority groups to start off with should be. But one of the areas, and Rose is here, she might remember which one it is, has specified homelessness. I think it might be Coventry. They've specified transient groups, transient communities, including refugees and asylum seekers, people with no recourse to public funds, homeless. So I can't remember whether it's Coventry or Warwickshire now, but yeah, so, but remember I said that it was about looking at the joint strategic needs assessment for an area that comes up through the health and wellbeing strategy for that area, and then prioritising that within the integrated care system. So it isn't about the integrated care system saying, Warwickshire, you will do this. I hope that is helpful.
Contact in the chat. Want to know more? Got 2 hands up. Oh.
To Danielle, the of equal.
Your microphone doesn't seem to be working properly, Bob.
I'm not muted. Can you hear me now?
That's better.
Oh, you've gone off again.
Let me try again, Daniel.
Would you mind putting it in the chat, Bob, because I can't hear.
Bear with me a moment. Yeah, let me just change this over again. Let's just see if it. Can you hear me now, Danielle?
Yes, I can, yeah.
Mentioned the importance of relationship of equals.
Yes.
And I'm particularly interested in this relationship between, obviously, the professionals and the voluntary sector. This relationship is crucial. You were the chair of the organisation, thereby set the culture for the organisation. What elements that you see importance in establishing this culture?
I gave one example, which would be regular meetings between leaders of the system, and that those leaders of the system included the leaders of the voluntary community sector. I think that would be a good way forward. Potentially, leadership development programs together, action learning sets, but actively being involved in, the decision making, sitting around the table together. But most of the ways of building trust and effective working relationships are actually by spending time together. So creating those opportunities for joint pieces of work, joint development, joint activity that builds each other's understanding of the value that each other brings.
That's great. Thank you. Some good words there. Thank you. Phil.
Thank you, Chris. I'm really very interested in the development of the collaborative approach. Particularly interested in, because I'm a trustee at Marianne Hospice, particularly interested in the collaborative approach towards end-of-life care. And I'm hopeful, very hopeful that will begin to give us a method of working which works much better than we've been able to work together in the past. What I'm more interested in at the moment, though, is asking a question about the funding streams, because one of the experiences that I've had in trying to help organizations work together is that what gets in the way is the way they actually get funded from central government to local government and through the health service, and how they come into contrast with one another and don't necessarily encourage people working together. Any ideas about how the integrated care system will begin to tackle that particular problem?
Yeah, you've hit the nail on the head, and probably most of us have been around and seen initiatives such as Total Place and other partnership-based approaches that fell when people had to put their hands in their pockets. I think the reality is at the moment, the constituent members of the integrated care system are all sovereign organisations. But obviously, the role of the Integrated Care Board is the allocation of NHS resource. So from that perspective, we will have influence set in the context of the strategy that we've agreed. So what we'll need to do, there's no silver bullet. What we'll need to do, like any other collaborative approach, is to start off by working on things where we can demonstrate the benefit of this way of working, and then build the momentum from there. Some of it, people can already see from the time that they had to work together in the pandemic, and the fact that they were able to, take decisions quickly, overcome things that they would have been competing against and do it jointly. So there are examples, but we're going to have to build on that. We're not in a position to sort of force, you will like and trust each other. That's not going to how it's going to work, I'm afraid. So I know I've overused the phrase journey, but I think that is the reality. We need to say how we want to work together, how we want to believe and behave towards each other. And then we need to start doing it. And as we're doing it, acknowledging and recognizing that we're doing it, that it's been successful by having data that backs up what we're doing, and then doing some more of it.
That's excellent, Daniel. Can I just confirm that Warwickshire Community and Voluntary Action is very much up for this challenge, and we'd want to join with you as effectively as we could to build on what's happened during the pandemic.
Brilliant, thank you. Really good to hear that.
Great stuff, Phil. Thank you. We're running out of time rapidly. Deb has just been nudging me to say we've got 5 minutes left. So I've got your hand up, Sue. Is it going to be fairly brief? Very brief because it's muted, Sue, unfortunately.
Sue, can you put it in the chat because we can't hear you?
Yeah. Whatever the question is, could you just stick it in the chat for us, please, Sue? Thank you. Well, with 5 minutes, well, actually 3 minutes left now, Danielle, is there anything you want to say in summing up the discussion and where you see it going from here?
Well, the next steps are really to put your views and your contributions by being actively involved when Rose comes out to you, but to really leave you with the understanding that this is really important, and this you know, it is an opportunity. I know for those of you who've been around a long time, you can feel a bit jaded and feel as though you've heard it all before, and I'm sure you have, but be that as it may, we've got to seize this opportunity. And, you know, as long as I'm here, I will be wanting you to be involved.
Yep, that's a powerful message. And I have to say, I feel more optimistic about this reorganisation than I have about previous ones. I have to say that. So can I thank you, Danielle, for giving up an hour of your time 2 weeks before the launch of the integrated care system. I think that shows the importance that you place on these relationships and working together. So I want to thank you so much for doing that. Thoroughly enjoyed the presentation, and I learned a lot from you today. We hope this will be the start of a conversation and not the end, and that it will be a continuous dialogue with Danielle. Any questions that haven't been answered, either that you wrote in, you put in the chat, or anything else, we will forward to Danielle so that she and her staff can deal with them in due course. So the only thing that's left for me to do really is to thank everybody for coming along and for your full participation. I hope it's been helpful, and I look forward to seeing you all again at a future meeting. So thank you all so much.
Thank you, Chris.
Quickly answer a question about the presentation being passed along. We will be putting the recording and the transcript on our website, so that anyone can access it again if they would like.
Okie doke. Thanks then. Can Health Watch people stay on for a minute, please?